After all those beautiful talks, we're just going to talk about cataract surgery in a special situation, and I'm going to be talking about Fuchs. Basically, as this is a resident sitting, I would advise everyone, whenever you're starting your phaco, to start it as a special situation. If you get used to dealing with your daily phacos as a special situation, then you will not have any problem dealing with real special situation cases. So the first step is when the patient arrives to your clinic is suspicion. Then we have to confirm that. We'll take the right decision of what procedure we will do. I'll talk a little bit about intraoperative protective measures and postoperative care. So suspicion, this patient comes, they complain of the sometimes hallus, disturbance with light, the morning edema. You do your bimicroscopic examination. Every cataract surgeon needs to know how to examine for the endothelial cells to find the guttata or to discover even minimal edema clinically. Once you suspected that this patient is having low endothelial cell count or having Fuchs, then you have to confirm your suspicion. The confirmation can be either by knowing the endothelial cell count and morphology, by doing confocal or specular microscopy, and by corneal thickness through anyway ultrasound or topography. The endothelial cell count, you have to know the normal. It's an average of 2,500 per millimeter squared. It ranges from 2,000 to 3,200. In another study, they were doing the average cell count and they compared it with age, and there was a decline with age until the age of about 50, where there is no much appreciable difference between the age groups. The confocal microscopy we use to check for the count and morphology. Basically, it is called confocal because both focal points come into one focal plane. It started as the confocal and used to test only one layer of the cornea, but then it evolved. That's why we have the specular microscopy right now. In confocal studies, every layer of a patient with Fuchs endothelial dystrophy has changes from the epithelial to the Bowman's, the anterior and posterior stromi with the lacunae and the dark bands. Every layer basically have changes, and the mean endothelial cell count in those patients was around 1,200 plus or minus 850. The second way of confirmation is corneal thickness. Again, we have to know the normal. The normal is average between 540 to 560, but this normal is different in different areas. In our region, it is less than that, about 515. A thick cornea is 565 or more. A very thick cornea is 600. So the mean is around 540, and there is increase in corneal thickness in every patient with Fuchs, even if you don't see the clinically observable edema. Now you have to take the decision whether you're going to go for phacoemulsification alone or you're going to go for phacoemulsification with endothelial keratoplasty. And here where comes patient counseling. And I'm very happy that in this meeting, everyone was talking about patient counseling and talking to patient. In our region, this was a little bit of a deficient area, I have to admit. Now, we used to say that patients wouldn't understand this, but they do understand. Every patient has the right to understand what is going on. So patient counseling is very important. He needs to take the decision with you. The density of cataract, how mature is that? How hard is that? Much energy is going to be used, is going to cause more endothelial damage. The presence of already corneal edema may make you take the decision to go for an endothelial solution. It says that if the corneal thickness is 600 or more, then there is a 10% chance that the patient would go for endothelial keratoplasty. But if it's 640 or more, there is 90% chance that he would go for it. Now, you have taken the decision to go for either phaco alone, and this can be conventional versus femtosecond. You can use, as Dr. Saati mentioned, the soft shell technique or any technique, but you have to use dispersive viscoelastic. And then the phaco technique itself. The triple procedure, you have to put your location of your phaco entry that is suitable for the endothelial keratoplasty. Epithelial removal may be needed to facilitate better view. use tools to help your surgery, and calculate your IOL power to help later on. Another procedure is the dysmatorexis, which is newly introduced, and this is where we only remove the descending membrane without replacing it with a tissue. So in phacoemulsification, few of the tips. The first tip, which is very important in all kinds of surgery, is the proper wound construction, as Dr. Wala mentioned in our first day. A square limbal wound or a super square limbal wound. It is very important, so you can have a trauma-less phacoemulsification. The viscoelastic use, the dispersive, the soft shell technique, or at least use dispersive viscoelastic. The capsular exercise, so you would make sure that the lens wouldn't pop out and in when you reach a stage where you implant it. Personally, I like the CHOP technique, the pulse mode, less energy, more off time, and work in the capsule bag. With using the dispersive viscoelastic, you will find sometimes cortical material attached to the endothelium. Don't try to dig for those material. Don't try to get them. They will come to you at the end of the procedure, because then you will remove the viscoelastic and you will decrease the protection to the endothelium. Make sure the irrigation port direction is sideways. Sometimes when you're removing your phaco-tip, it moves up and down vertically, and this is going by itself to cause harm to the endothelium. And of course, the IU power selection, you go for a more myopic if you're anticipating more that you will have the endothelial keratoplasty later on. When you do a combined or triple procedure, it is a procedure that is planned before. The difference is that you have to make your IOL power according to you're doing DESIC or DEMIC. You have to know that this procedure does not affect negatively the endothelium transplantation procedure, so it is fine to go for them simultaneously if required. The last update is the dysmatorexis. Without transplantation in Fuchs, it was introduced by Dr. George in the American Academy 2015. They noticed spontaneous corneal clearing following the dysmatorexis. They intentionally removed it and did not replace it. And they reported good spectacle correction of 20/20 in 12 months in those two cases. So the basic behind it is that clinical and confocal microscopy suggests that there is a mitotic and migratory healing capacity of the human corneal endothelium that can exploited in these cases. But of course, this is an area of further study and research. Lastly is the postoperative care. If you talk to your patient preoperatively and counsel them, then you will be confident that they will understand that sometimes they may have corneal edema postoperatively, but reassure them that this may clear up. Use the steroids more frequent and in a longer duration. And you have to know when to go for endothelial keratoplasty. Should you wait for 6 weeks for the edema to recover or 3 months? And it depends, of course, on your follow-up. How do you see that edema is improving? So in summary, preoperative suspension diagnosis, preparation, and patient counseling is very important. Intraoperative measures to minimize endothelial cell loss needs to be taken. And postoperative medication and follow-up is crucial in these cases. Thank you.